Hello, welcome my dear students on this particular session. And this particular session is about aminoglycosides. Aminoglycosides, extremely important chemotherapeutic agents, antimicrobial agents, which mainly affect the gram-negative organism and especially the aerobic organisms. Let's have a look. What are the general characteristics of aminoglycosides? Aminoglycosides have a poor oral absorption. A very important thing to remember. You think of giving them as tablet or capsule by oral route of administration is not going to get sufficiently absorbed. It's not going to achieve required plasma levels. And this is why the route of administration for aminoglycosides for systemic purposes will always be a parenteral route, an intramuscular or intravenous injection. If you're going to forget this, I would just remind you of streptomycin, which is an anti-tuberculosis agent aminoglycoside and is always injected. This would probably help you to remember aminoglycosides, no oral route of administration for systemic purposes. Just as they don't have oral absorption, they also cannot enter the cerebrospinal fluid. There's very poor entry in the cerebrospinal fluid. So you can't rely upon them for those infections which are happening inside the brain. The next important characteristic is they are bactericidal agents. They are bactericidal. They're going to kill the bacteria. By what mechanism? By inhibiting the protein synthesis. And they are going to go and bind with the 30S ribosomal subunit and then further lead to inhibition of protein synthesis. That's common for all aminoglycosides. We already said they are active against gram-negative aerobic infections, aerobic organisms. All of them, they can form water-soluble sulfate salts. This is a common chemical characteristic for aminoglycosides. They get concentrated in the urine, they get concentrated in the kidneys, they get concentrated in the middle ear fluid, that's your endolymph, and most importantly, they are excreted almost unchanged in urine. So the whole drug is going to the kidneys and going to the urine in the form which is active, and they are not metabolized, they are not broken down. They are going there in the form which is unchanged, and that possesses a great important significance that the renal elimination, the renal excretion is going to be almost proportional to the glomerular filtration rate. So the renal elimination is proportional to glomerular filtration rate. We need to keep this in mind. We're going to explore this fact later. Lastly, the aminoglycosides demonstrate a very typical phenomenon, and that's called post-antibiotic effect, PAE, post-antibiotic effect. We're going to discuss this on our module further. We go to the next slide. Aminoglycosides classification. Aminoglycosides which are used systemically by the route of injection for the systemic purposes. Look at the examples on the slide. Streptomycin, Gentamicin, Amikacin, Tobramycin, Sisomycin, and Netilmycin. So most of the names are ending with mycin. Only Genta is Gentamicin. Aminoglycosides, many of them end with mycin. Vice versa is not true. If a drug ends with mycin, it may not be an aminoglycoside. Just remember vancomycin and clindamycin, they are not characteristically aminoglycosides. So the drugs used systemically by injection, that's by parenteral route of administration for systemic purposes: streptomycin, gentamicin, amikacin, tobramycin, sisomycin, netilmycin. The next group, these drugs are not used for systemic action. Then what? You give them, but they are used for local purposes. They are going to produce the local effects. Very concrete example is neomycin, which is used by topical route of administration in the form of skin ointment, say powder to be applied in the skin or wounds or burns, and it can also be used by oral route of administration. What will happen if it is given by oral route of administration? It's not going to be absorbed systemically. So what is it going to do? See, you put the drug by oral route of administration, there's no absorption, but the drug is not also broken down by gastric hydrochloric acid, so the drug remains active, and the drug keeps on passing through the gastrointestinal system in the form of an active drug, and then during the passage through gastrointestinal mucous membrane, it can kill the bacteria. So it's a kind of local use. It's not systemic use because the drug is not going to the systemic circulation. In this way, you can use neomycin for pre-operative preparation of bowel, or you can also use it in hepatic coma. We are going to explore this fact later. And another one is gentamicin, which is also available in the forms of eye ointment, eye drops, ear drops, and also to be applied to the skin, wounds, burn, etc. So that's my way of classifying those used systemically for systemic effects and those who are used by other routes, that's not the systemic effect, but by local route or by topical route. May it be oral route of administration, but it's not for systemic effect, it's for local effect on the gastrointestinal tract. Let's have a look at the mechanism of action. We already said they inhibit the protein synthesis, they interfere with the initiation of the codon function, and they bind to the 30S ribosomal subunit. After binding to the 30S ribosomal subunit, they block the association or joining of the 50S ribosomal subunit with the mRNA 30S complex. So what is it going to do is it's going to prevent the formation of initiation complexes, is going to prevent the translocation, is going to cause misreading of mRNA, and is going to cause incorporation of wrong amino acid. So all this is going to lead to inhibition of protein synthesis, and the major binding site is the 30S ribosomal subunit. A very important fact on this slide, if you could have a look at the slide, they are accumulated intracellularly, means the bacterial cell is going to take it inside via an oxygen-dependent uptake. Oxygen-dependent uptake. And only those organisms who have this oxygen-dependent uptake, they will be able to take the aminoglycoside inside. And that's why I said they are exclusively useful against the gram-negative aerobes, because the aerobes are going to have this oxygen-dependent mechanism, and therefore anaerobes are innately resistant to the action of aminoglycosides, because aminoglycosides cannot enter the anaerobic bacterial cell. So it's good enough to remember aminoglycosides, gram-negative aerobic infections. We move on to the next slide to have a look at the toxicity. And it's good to discuss the toxicity of aminoglycosides in general for all the common adverse effects of aminoglycosides. The toxicity includes, number one, nephrotoxicity. They are damaging to the kidneys, and we also saw the mechanism. See, they are going to go to the urine, go to the kidneys in active form. They're not going to be broken down, and their elimination or excretion is going to be proportional to the GFR. Naturally, you expect nephrotoxicity or acute tubular necrosis. Let's have a look at the slide, and the slide is showing you all the toxicities. Number one, as I said, nephrotoxicity or its acute tubular necrosis. The second one is ototoxicity. I hope you're reading on the slide, and that's the 8th nerve toxicity. That's the vestibulocochlear toxicity. This vestibulocochlear toxicity can be variable in different aminoglycosides. In few, it can be a vestibular component, and in some others, it can be a cochlear component. The next toxicity is neuromuscular blockade. Neuromuscular blockade. I hope you remember a substance which is skeletal muscle relaxant or a nicotinic blocker. It is going to block the nicotinic receptor. What do aminoglycosides do? They produce decreased release of acetylcholine. So it's as good as skeletal muscle relaxation, and it's a neuromuscular blocker. And the last toxicity, as you see on this slide, is contact dermatitis. And this contact dermatitis is especially known with a substance, neomycin, about which we said that neomycin is most probably used for local effects. We move on to the next slide to explore the toxicities more. And the first toxicity is nephrotoxicity. This nephrotoxicity with aminoglycosides is about 6 to 7% of patients, and the characteristic is tubular necrosis. The tubular necrosis of the renal tubules. I would like to remind you something. There are more drugs which are nephrotoxic. For example, penicillins can be nephrotoxic. Cephalosporins can be nephrotoxic. And if you remember your module on penicillins and cephalosporins, we said they are also nephrotoxic, but they produce acute interstitial nephritis. So that's the affection of the interstitial cells. That's interstitial nephritis. So interstitial nephritis, characteristic for penicillin cephalosporins and aminoglycosides, is tubular necrosis. Please remember this. With the nephrotoxicity, you could get proteinuria, hypokalemia, and acidosis. And the most nephrotoxic aminoglycoside is gentamicin. Please remember the name of gentamicin is supposed to be the most nephrotoxic aminoglycoside. Now, you need to take precautions if this patient, your patient, is receiving aminoglycosides and is simultaneously receiving some other drugs which are also nephrotoxic. Have a look at the slide. I'm saying nephrotoxicity by aminoglycosides is enhanced by which drugs? Firstly, vancomycin. Vancomycin is extremely nephrotoxic, so you will have to take precaution while giving an aminoglycoside and vancomycin together. Sometimes you are in such a situation. The second important nephrotoxic drug is amphotericin B. Amphotericin B is a useful antifungal agent, a broad spectrum antifungal agent, and its main drawback is very severe nephrotoxicity. So you need to take care if your patient is receiving aminoglycoside and amphotericin B. The next on the slide is cisplatin. What is the cisplatin? This is an anti-cancer agent and it is nephrotoxic, so you need to be careful. And another agent is an immunomodulator substance is cyclosporin. So vancomycin, amphotericin B, cisplatin and cyclosporin, you need to follow precautions if you are also going to give aminoglycoside along with these drugs. We move on to the next slide. The next toxicity under discussion is ototoxicity, and that's eighth nerve damage, vestibulocochlear nerve damage. It happens in about 2% of patients, and what happens is hair cell damage. I hope you can see the slide. Hair cell damage. This can lead to deafness, and this deafness may be irreversible. That's very important to remember. So you have to be extremely cautious while using aminoglycosides, and you need to monitor the vestibulocochlear functions of the patient. The second toxicity is vestibular dysfunction. So it's not about hearing, it's about balance, equilibrium, etc. That's vestibular dysfunction, and this vestibular dysfunction may be reversible. So that's regarding the type of ototoxicity. We call it vestibulocochlear toxicity. And just as I said in the beginning, some drugs may be more toxic to the vestibular component and some others may be more toxic to the cochlear component. So look at this, gentamicin and amikacin. These two substances produce more cochlear toxicity. Now there is K in the spelling of both these substances, that's gentamicin and amikacin, and amikacin is a derivative of gentamicin. So that could be the reason the similar structures, they are responsible for cochlear toxicity. Look at the slide. The next two substances mentioned here is streptomycin and gentamicin. Streptomycin and gentamicin have got more susceptibility to cause vestibular toxicity. So cochlear component, gentamicin and amikacin, and vestibular component, streptomycin and gentamicin. You need to remember this because you might have to pick up which of the toxicity is more likely to be common with a particular agent from aminoglycosides. This toxicity also can be enhanced by certain agents which are known to be ototoxic. And I hope you remember most important agents are loop diuretics. Loop diuretics, examples, furosemide, bumetanide, and ethacrynic acid. If you have a look on this slide, I have written ethacrynic acid in red. This is the most ototoxic of all the diuretics, and you need to observe precaution, and especially ethacrynic acid has got a flat dose response curve, and this is why the toxicity is more likely to be common. So you need to take care if your patient is receiving an aminoglycoside and loop diuretic, and also as the thiazide diuretics. Again, the name of cisplatin is coming here because cisplatin also does produce ototoxicity. So that's regarding the ototoxicity or eighth nerve toxicity, vestibulocochlear toxicity. We move on to the next toxicity, that's neuromuscular blockade. We already said the aminoglycosides have got this particular effect and adverse effect, They decrease the release of acetylcholine. There will be skeletal muscle relaxant effect, and this can lead to weakness and fatigue in the patient. And this toxicity can be enhanced by certain agents, obviously, who are neuromuscular blockers. I hope you remember the neuromuscular blockers in the form of skeletal muscle relaxants written on this slide. The older one, D-tubercularine, and amongst the newer ones, pancuronium. That's one. Next, the general anesthetic agents, ether and enfluorine, they also have got a liability of producing skeletal muscle relaxation. And in case of these agents, we say they have got a curary mimetic effect, the effect like D-tubercularine. So these two agents can produce on their own this particular toxicity, that's the excess skeletal muscle relaxation, and you need to take a precaution if your patient is receiving aminoglycosides. Lastly, I would like to mention of a disease, myasthenia gravis. In this disease, you already suffer from deficiency, you already suffer from some receptor dysfunction, and naturally the patient will be having muscle weakness. So the patient with myasthenia gravis, you need to be cautious while giving aminoglycosides to the patient. So this is regarding the common toxicities of aminoglycosides: ototoxicity, nephrotoxicity, and the neuromuscular blockade. Let's go on to see what's the spectrum of activity, what are the organisms on which aminoglycosides are going to act. E. coli, Klebsiella, Proteus, Pseudomonas, Serratia. We should feel happy. They are useful against very important microorganisms from the gram-negative organisms. That's E. coli, Klebsiella, Proteus, Pseudomonas, and Serratia. Next important organism is Vibrio cholera, and Streptomycin is useful against cholera. The next one, I hope you have heard this organism, is called Yersinia pestis or Pasteurella pestis, and this produces plague, and Streptomycin can be used in the management of plague. The next organism is Francisella tularensis, producing tularemia. You can use Streptomycin against this, and also Brucella, producing brucellosis. Plus some aminoglycosides can be used against Enterococcus, and some aminoglycosides are useful against Mycobacterium tuberculosis, which is an acid-fast bacillus. Lastly, aminoglycosides have got a capacity to inhibit Staphylococcus aureus and Streptococcus viridans. That's very typical. So we are talking of a group of agents which are mainly effective against gram-negative infections. But look at that, as you go down, they are able to inhibit the acid-fast bacilli, also that's Mycobacterium tuberculosis, and two important gram-positive organisms, that's Staph aureus and Streptococcus viridans. So that's about the general spectrum of aminoglycosides, and we now start discussing few important lines about each of the individual drugs. Have a look at the slide. The first one is Streptomycin. Streptomycin is a drug which is mainly reserved for the management of tuberculosis. I hope you know, with the advent of the HIV disease, the incidence of tuberculosis has gone up, and you really need effective agents to treat tuberculosis. Streptomycin is a cidal agent and becomes an important agent in the management of tuberculosis. The only disadvantage is this drug cannot be used by oral route of administration. You have to inject it. That's okay, but tuberculosis. 750 milligrams, that's 0.75 grams, to 1 grams intramuscular injection every day for 2 months is one practice. Otherwise, this can be injected 3 times a week. That's another practice. Next, as we just said, is useful against bubonic plague, and it could be combined with tetracyclines or it could be combined with cotrimoxazole. Next important indication is tularemia, which we already mentioned. It could be given with or without tetracyclines. The next one is brucellosis. Again, it could be used with tetracyclines or it can be used with rifampin. And the next important indication for streptomycin is cholera. So tuberculosis, bubonic plague, tularemia, brucellosis, cholera. Lastly, we mentioned about staphylococcus and we mentioned about streptococcus. So you can think of using it against endocarditis. The toxicity of streptomycin, we already discussed the general toxicity. So we can only say the important points about individual agents. Streptomycin affects the vestibular component more as compared to the cochlear component. And the common symptoms observed are vertigo and loss of balance. It can lead to hypersensitivity reactions. These drugs are to be injected, so it's very important to have the hypersensitivity testing before using these agents. Streptomycin also crosses placental barrier. That's important to remember. And let me add, it also crosses the milk barrier. The significance of crossing the placental barrier is important. I would like to remind you that streptomycin is in the pregnancy risk category D. So it's going to be highly toxic. As you go down A, B, C, D, E, as you know, the drugs are more and more toxic as the pregnancy risk category. So streptomycin will be phytotoxic, and it's in the pregnancy risk category D. The next agent for discussion is gentamicin. It was very popular and it was very widely used once upon a time. Now we have the newer drugs from aminoglycosides like amikacin and tobramycin, which are used more commonly these days. But gentamicin was the mainstay of gram-negative aerobic infections. So gentamicin is useful against serious gram-negative infections. Once again, we already mentioned the spectrum, general spectrum. So out of it, we must mention Pseudomonas, Proteus, Klebsiella and Serratia. That's quite important. You can use it against resistant urinary tract infection, pneumonia, peritonitis and meningitis. 4 important indications for gentamicin. You can also use it against septicemia, post-operative or nosocomial infections, which are most likely to be due to these gram-negative organisms, and sometimes it could also be used for pre-operative prophylaxis. Nextly, the obstetric and gynecological infections are likely to be due to these gram-negative organisms, and that's why gentamicin is useful in obstetric and gynecological infection. Many times it's combined with penicillin. It may be ampicillin, it may be amoxicillin, or it may be carpenicillin or ticarcillin. Next, gentamicin is useful for burn infections, wound infection, and osteomyelitis. It's got good penetration in the bones. It can be used to prevent intravenous line infections, especially if the patients are in the intensive care unit setup, especially if the patient is in the hospital for a longer time and is receiving the drugs by parenteral route of administration. The patient is having constant intravenous lines, and these intravenous lines could get infected. Gentamicin will be useful. Gentamicin is useful against Streptococcus viridans and Staphylococcus endocarditis. And this is why we mentioned these 2 important organisms, Streptococcus viridans and Staph aureus. Gentamicin is also used topically. Let's go to the next slide. What are the topical uses of gentamicin? It is useful in the form of skin ointments, creams and lotions. It's useful as ear drops. It's useful as eye drops and eye ointments. It's useful to treat the skin infections, wound and burn infections, eye infections and ear infections. So that's important about gentamicin. You can use it systemically by injection, and it's available in various forms, various formulations for the topical application. Gentamicin is most nephrotoxic aminoglycoside. We said it in the beginning. And the toxicity is tubular necrosis. It's most nephrotoxic. So it really matters if your patient is suffering from renal damage, already suffering from renal damage, what to do and how to manage this particular issue. Another important thing is gentamicin is not amenable to dialysis. It's very difficult to remove gentamicin out of the body. It mainly affects the vestibular component and produces also high frequency hearing loss and the hair cell destruction, which is a systemic action of gentamicin when you use it by systemic route of administration. That's the 8th nerve toxicity.